Thank you. Good afternoon. I come at this topic also from years of working with and treating survivors of childhood sexual abuse, and then 10 years of working with refugee, war trauma, and torture survivors at the Center for Victims of Torture. So I'm going to be talking, I envisioned I'll be using those types of examples through the talk based on my experience with trauma. When I saw the original webinar that was done on assessment, I envisioned myself actually building on that, and Peter asked me to speak a little bit about interviewing without re-traumatizing or promoting re-experiencing, and I thought that's an interesting topic. So why don't we try to go through it, and hopefully it will build on knowledge if you saw the previous webinar without being too repetitive. So, so we're going to talk about interviewing and assessment. I'm going to look at, first of all, what do people mean by re-traumatization, and then talk about understanding the effects, psychosocial responses to trauma, diagnoses associated, and focus on interviewing, establishing trust and safety, how to do assessment, and a little bit on cross-cultural interviewing, although we have 45 minutes, so I may not get through it all. First of all, when people talk about defining re-traumatization, I just put this slide in to say they talk about a couple things. First of all, sometimes the term in the literature is used to talk about second or repetitive experiences of trauma being the same or different. So a rape survivor maybe is more likely to get raped a second time, or someone has a car accident and then they're in a fire. So a direct kind of re-experiencing of a different kind of trauma. The second way that people talk about re-experiencing is using the re-triggering of flashbacks and traumatic experiences due to exposure to similar situations or triggers. So in other words, people are very concerned in interviewing survivors that you don't promote re-experiencing by re-triggering symptoms and distress and suffering simply unnecessarily in an interview. Without it being re-triggered in the context of a therapeutic session, or where you're actually really working on those symptoms. So that's what I'm going to talk about today, and I'm going to talk about it in the context of interviewing, what I've learned in terms of what works and doesn't work, and what are some strategies for not re-traumatizing survivors in that initial assessment interview. So let me go back to what was discussed in the previous lecture in terms of evidence-based practice. A lot of it is based in exposure therapy. And I'm assuming some of you are familiar with that. And exposure therapy is based on the reactivation and resolution of a fear network. So let me just, in order to understand the difference between treatment and re-experiences that is based that is about helping versus re-experiencing that is creating a lot more symptoms. I'm just going to go back to understanding the fear network and illustrate it for you a little bit, and then talk about interviewing. So during trauma, here's one way of understanding what happens. The sensory and perceptual information, sounds, smells, et cetera, are stored in a memory during a highly emotional state. Sometimes this is called implicit memory. The mind and body become extremely aroused and are set for action, fight or flight. And this emotional and sensory information is often stored separately from information related to content, which is in your hippocampus. We call it declarative memory. So this creates a re-triggering. It's stored in an interconnected neural network from which a fear network is established. This includes the sensory, cognitive, physiological, and emotional experiences. And those things can be re-triggered by similar sights, smells, and sounds. So because trauma is not processed initially, what triggers re-experiencing is a smell that smells like a place you were when a trauma took place, or a sound, or a sight That is enough to re-trigger symptoms and suffering in trauma survivors who have not received treatment. That's what the exposure folks call a fear network or a fear structure, which you see in prolonged exposure. So let me give you just a quick example so that you can understand what we are trying not to re-trigger too much in the initial assessment interview. So here's a child in Sudan who came home from school, and you can't see the cartoon or the drawing, but it's a drawing of planes coming and bombing the person's town. And the child said, in the afternoon we returned from school and saw the planes. We were all looking, not imagining about bombing. Then they began the bombing. The first bomb landed in our garden, then 4 bombs at once in the garden. The bombs killed 6 people, including a young boy, a boy carried by his mother, a girl. In another place in the garden, a woman was carrying her baby. She was killed, not him. Now my nights are hard because I feel frightened. We became homeless. I can't forget the bad images of the burning houses and fleeing at night because our village was burned. Okay, so you get a sense of all that chaos all at once. This is trauma. Now, if you dissect it, looking at the fear network, the child is recounting a lot of sensory elements. I saw the planes, the bomb landed, the bomb killed, these are all the things I saw. There were cognitive elements in that story. Not imagining about the bombs, I can't forget. There were emotional elements. My nights are hard, I feel frightened. And there were no physiological elements because they're not really integrated into her story. But they would be things like, I froze in the garden, my heart was beating fast, I was breathing fast, I couldn't catch my breath, my body was hot, my hands were sweaty. When you do exposure treatment, all of that information gets integrated into a declarative memory so that it no longer pops up as a symptom, as a re-experiencing. That's what exposure treatment is about, in short. So that's just a quick review on what treatment is. Now I want to talk about how then do you navigate the general psychological effects of trauma, psychosocial consequences, without re-triggering a whole cascade of symptoms that are not useful in the interview and you are not in the context of doing an organized trauma treatment. Okay? So these are some of the generalized challenges for interviewing that I'm going to talk about. Fear, distrust and social isolation, shame, humiliation, especially in the context of interpersonal trauma, helplessness, hopelessness and guilt, shock, denial, disbelief, rage. All of these general psychosocial effects of trauma create challenges for interviewing. It bears witness to say that although trauma may involve physical pain, trauma survivors often report that the psychological damage is the most difficult to endure and remember. And that's across the board with trauma survivors that I've dealt with, and that is one of the hurdles to interviewing effectively because you're in an interpersonal context and the psychological damage is right there in the relationship. So let me kind of read some of these and talk to you about it. I think I'm going to walk over here for a minute so I can see my screen without turning around. So many times abuse is perpetrated by authority figures such as medical personnel, teachers, therapists, parents, soldiers. And this makes the initial task of trusting authority very difficult because trauma survivors come in and they expect to be re-traumatized in the relationship. They have no reason to trust you. And that's true even when trauma is not of interpersonal design. If you listen to the 35W bridge survivors, they talk about how trust is an enduring problem for them. They no longer trust in the world, in others. The world may not be as one expects it to be. This creates a lot of challenges for interviewing right off the bat. And since trauma is often of human design, trust in authority will be damaged at very deep levels. Interpersonal trauma survivors uniformly avoid human interaction. They report shopping at night, avoiding public fairs. They don't like restaurants, crowded places, malls, all sorts of things like that. This is largely because they know what human beings are capable of doing to one another, and they just do not trust people. So this makes the job of interviewing extremely challenging, requires a lot of patience to establish trust, and in particular to validate the experiences that survivors have in this regard. So some strategies might be acknowledging that it's very difficult to come to treatment. Sometimes people they contemplate it for years before they come to treatment. And part of establishing trust is acknowledging the difficulty of coming in the door and sitting with you. I also recommend to students that they spend a lot of time up front in an initial interview addressing trust issues and these challenges, especially if you have an hour to do an assessment. It pays off spending 10 minutes establishing trust, just establishing trust. So because otherwise, a half hour into your interview, you may not be getting the information that you want. So that's really the first hurdle, I think, in not re-traumatizing, is establishing and forming a treatment basis of trust right from the get-go. Helplessness is a common response that can also interfere with interviewing. Interpersonal trauma victims often have no control over what happened next during captivity and victimization. They maybe have been rendered helpless in their perpetrator's hands. Survivors often continue then to struggle with a sense of helplessness even after they've gained safety and are no longer being abused. Helplessness makes it difficult to assert oneself, to think for oneself, to express oneself when survival depended on silence. So any child survivor will tell you that. And if you suddenly ask a simple question in treatment like, what do you think about that? This can be a little bit humiliating for survivors who've not been allowed to have an independent thought for a very long time. They may have no thoughts, may feel stressed. It might be quite difficult. Survivors also struggle with helplessness due to feelings of guilt about what they did or did not do in captivity. Guilt can make it very difficult to make decisions on their own behalf, to follow through with referrals you might give them. Helplessness and guilt that survivors are struggling with from the outset can be very misinterpreted as not making efforts on their own behalf. So for example, you might give a list of referrals and watch your client drop the piece of paper in the parking lot on the way out of the building. And it's not that they don't want to engage in treatment and help themselves, but the idea of having to make a decision or take an action on their own behalf can be very difficult. So I have the example of Sophie's Choice situations. There's a lot of examples of this in the literature. If you see the movie Good Will Hunting, you see the boy, his dad asks him to choose his instrument of torture. Do you want to be beaten by the wrench or the belt or whatever it is? In a Sophie's Choice situation, it was, which child do you want to die? The important thing for survivors to understand in treatment is that these are not real choices. You know, the real choice would be to not be there, to not be in captivity, to not be being tortured, to not be being abused or raped or whatever. So survivors, and even in the context of war, this is very common, are often placed in situations where they're made to feel responsible for their own victimization or the victimization of others. Then they do other things that are quite harmless, like I was running from the burning building and I was so afraid I didn't stop to help that old person and that person's probably dead now. Or the flood was coming and I couldn't get that baby and I saved myself instead. Those kinds of moments of guilt, which choices anybody might face that are not real choices, can be immobilizing to survivors, and it can render them a little bit quiet and unhelpful when you're engaging with them in treatment. So talking about that, those are interesting waters to navigate in order to avoid re-traumatizing. Shame and humiliation are often intentionally produced to undermine people's identity and prevent people from talking about what happened to them. The most common, of course, is rape or any kind of sexual victimization, forced nakedness. These things are used to silence people. I've had survivors who were told not only no one will believe you, but you're nothing but a whore and a prostitute. The implication of that kind of language for silencing and intimidating victims, in my class is reading Precious right now, where the abuser tells the child that they must really want this and they're, you know, hot for the abuser, etc. This kind of language implies that if they were not a whore or a prostitute, they would not be getting raped right now, or they would not be in this situation. So again, it assigns blame to the victim. And that kind of humiliation gets internalized and makes it very difficult for survivors to actually talk in a diagnostic interview about things that have happened to them. It makes it impossible for them to talk in a court situation about sexual trauma, because so much blame gets internalized through the act of trauma, and then here they are in treatment with you in an interpersonal situation where they suspect you also will shame and humiliate them for their victimization. And that can make interviewing without re-experiencing, in terms of re-experiencing the shame, quite difficult. It requires a tremendous amount of normalizing and validation on the part of the therapist doing the basic interview. There are these added definitional issues that make it difficult in discussing rape. In other words, what is rape? Many people don't know. Sometimes it's best to just ask about sexual violation of any kind, unwanted sexual contact, and to really normalize the fact that this is common in traumatic situations. Shock, denial, disbelief. Survivors often struggle with believing their own shocking experiences and are told no one will believe them. They tend to tell often part of their story and then look to you, the clinician, to find out if you're believing that, if you're validating that. Then they might tell you a little more detail. They look to you both to help them believe their own story, but to see if you believe them as well. Part of the treatment is helping clients process their traumatic experiences in a way that allows them to face them and accept this trauma. However, in an initial interview, you're not there yet. So it takes a lot, again, of trust building. And I've added that it's important to be educated about the socio-political context of most trauma so that you're not shocked when you're interviewing survivors. And you don't convey that you can't hear atrocities that are very common experiences for women, children, soldiers, refugees, and other diverse groups of victims. So you want to, though they might be shocked and you might be appalled, you don't want to convey that in an interview in a way that creates a re-experiencing and shaming, shutting down experience for clients. So you want to be knowledgeable enough and always normalizing that whatever they're going to lay out on the table, you are going to be open to exploring, containing, and helping them with, essentially. Survivors who endure complex trauma can easily lose track of time, day, and night becomes confused because they haven't done that exposure piece that I described to you. So they literally don't know when things happened. Extreme traumas such as torture and rape involve a complete assault on the senses. So any sense of time and questions about timing can be very shaming because they don't know at the beginning of treatment, and that would be a common trauma response. Survivors can lose memory for details, and they may lack memories for how long things happened, what days, and you may spend time helping them reconstruct that in the treatment and even in the first interview a little bit. In order to do that and contain it, it is again important to validate confusion as part of the trauma, which helps address sort of the shame of not being able to remember. Often in an interview you want to know, okay, where were you, when did this happen, and when did the subsequent thing happen? And you start to ask basic interviewing questions, and survivors, they feel immediately shamed that they can't, or they'll say a year that's 10 years later. So if I'm sitting with a refugee and they say, so that was 2005 that we went into this Bosnian town, and I'll say, you mean 1995. You know, you want to say it gently but you want the accurate historical context to help them to, be able to start integrating the real story in a logical narrative for themselves. And you don't want to do too much of it. So in an initial assessment, what we're looking at is trying to understand the dates they understand while being validating and identifying points of confusion. So sometimes I'll say, so there's a 2-year gap here that we're not quite sure about, and that's understandable, and I think we can probably work on that. And this is very common in trauma situations, that we reconstruct some of these events. We figure out, if you were unconscious, we'll figure this out as we go, essentially. And that helps to kind of deal with avoiding re-experiencing about not remembering. Rage is, of course, the most common response to traumatic victimization due to the intensity of human violation and the immobility of victims in that fight or flight situation. Survivors have often been unable to express their rage during captivity or during the rapid pace of trauma, and they can be frightened by the intensity of their own rage as they begin to express those feelings. Helping professionals need to understand that rage, because they do go from 0 to 10 so quickly, can be turned against you in the clinical interview. And it might happen in an initial interview because you don't know you're touching on a hot spot or a trigger point for someone. So again, this is a situation where I'm very comfortable validating rage, and I tell them, these are real feelings, these are normal responses. I'm going to help you with them, and let's contain it for today and move on. But we know that this is important, and we want to get back and process it. So the diagnoses common with trauma, which were already covered, include post-traumatic stress disorder, major depression. I've seen survivors with brief psychoses that are very much flashback reactions to trauma. A lot of somatoform disorders in folks who are unable to emotionally express what's happened to them at the time. It may manifest itself in headaches, stomach aches, body pain. A lot of different cultural expressions of trauma that I don't have time to talk about here, but they're definitely there in other cultures. Any number of personality, anxiety, sexual dysfunction, substance use issues. More and more, at least in war trauma contexts, we're seeing traumatic brain injuries as part that also pose challenges in terms of resolving PTSD. And I'm going to talk just about interviewing related to diagnostic assessment of PTSD and depression today in the next 20 minutes in terms of recommendations for interviewing about symptoms like the ones we've just talked about without too much re-experiencing. So criterion A, of course, and this is will be updated with DSM V, but is experiencing or witnessing or confronting a life-threatening event. This usually results in these 3 classes of symptoms: re-experiencing, avoidance, and hyperarousal. And I'm just going to walk you through these symptoms with some examples. So survivors of trauma who have unintegrated trauma, like the example that I just showed you, often have recurrent, intrusive, distressing recollections. That's what re-experiencing is. And survivors, to the extent that they have a problem with re-experiencing, they will always be thinking about the trauma in any moment when they're not occupied, when their mind's not occupied. It is trying to process trauma. It's always available to be triggered by any passing thing. So re-experiencing is constantly thinking. It's recurrent dreams. Usually survivors have very concrete re-experiencing dreams where they're working out memories that are incomplete or have been unprocessed. So in my experience, survivors' nightmares will be concretely about exactly what happened to them, and often they wake up at the point that they're apprehended, the point that they can't escape, and then they do the dream again up to that point and again up to that point, and they're trying to make it come out different. or to process what you hope to help them process in treatment. And they can have flashbacks where they're acting as if the event is happening, and it brings on intense distress as symptoms when they're exposed to these cues. So a rape survivor who takes a bus and suddenly she realizes that there's only men on the bus, and she has a flashback to being trapped with men. Or I had a refugee who was imprisoned by the police in another country, had lived here perfectly fine for years, and suddenly a police car came up behind his car at a stoplight, and he took off, through a red light, took a left-hand turn, and the police thought, well, that's odd, and followed him and pulled him over. And he said, I don't know why I did that. And he said, here's my history. You know, I was in this country and the police used to imprison me and blah, blah. So the police officer very kindly said, okay, that's pretty messed up. I don't want you to do that again. And please go tell your therapist what happened. And then you can go. So that was a kind response. But that's an example of a flashback where you have lost the context with reality and you are back experiencing your trauma over again. Physiological distress when exposed to internal or external cues. People can have panic attacks. I've had survivors, a child abuse survivor, who could not tolerate the morning and afternoon commute because at some point her car would be stopped, trapped in traffic, and she would start to get a panic attack. I'm trapped. I can't move my car. Like, I've got to be able to get out of situations. So there's anything, if you listen to the interview of the bridge survivors, one of the girls says, I can't take elevators anymore because of the up and down. These are kind of physiological cues that bring back the full distress of the trauma. So when you're interviewing about re-experiencing with survivors, the point is you have to get the symptom to diagnose. So you are going to ask, have you had trouble re-experiencing? Or you're going to use an inventory, and I'll talk about that in a bit. You want to get enough of the content while minimizing the emotional reactions. And you don't want to tell people not to heal, and you don't want, or not to have feelings, and you don't want to be unempathic. So you're going, because you're forming a treatment alliance, so you want to listen as much as you can, but I'm always thinking about how to contain it. Okay, I have the information to know that the person has re-experiencing. And then I want to say, okay, it sounds like you have dreams about your trauma. We're going to have a time when we can talk about that more in depth. At this point, I want to move on and see if you struggle with other symptoms that are often common related to trauma. And you really want to contain it, because what trauma survivors will do is they'll start to tell you the whole thing. And then they're lost and they're off in their trauma, and you want to make that initial interview space safe. So that's what I do with re-experiencing. Here's an example of re-experiencing. Those of you you may know this artist from Chicago, Ivan Albright. You can see a lot of his art in the Chicago Art Institute. So he writes, it matters little whether I paint a squash, a striped herring, or a man. The space, the light, the motion, the position have one thing in common: decay. So I don't think he ever talked about having PTSD, but obviously he was a World War I medical recorder whose job it was to go around and draw the anatomy and the details of these war injuries. And every painting, if you go, I like to show this artwork because every painting, if you go to the Chicago Institute or you see his artwork, it's all of decay. You know, a beautiful woman looking in a mirror, and what she sees back is decay. I mean, this is what he specialized in, was documenting decay, and then became this famous artist. And in my view, this, like other works that are out there, the Crying, or what was the famous novel that became a movie about the kids hunting and bow and arrows, and yeah, anyway, somebody shout it out. Yeah, The Hunger Games. That gal very clearly says this is a book about children in war, and of course her father was in war and she was traumatized by his experiences. So, you know, there's a lot of this that you can see in art and literature. Avoidance is the second big class of symptoms, and these are, of course, the extreme efforts that the brain and the survivor's brain puts into avoiding experiencing these implicit memories of trauma. So they avoid thoughts, feelings, conversations. They may have avoided therapy for that reason, community members. Trauma survivors are often extremely productive, high-performing individuals, and they can contain their symptoms through being workaholics. In other words, avoid everything through work. They avoid activities, places, relationships that might arouse recollections of trauma. They may have an inability to recall important aspects of the trauma, though they were never knocked unconscious. And so that also is an effort at avoidance. And it is not unusual, actually, to sit with survivors who, in each successive treatment session, remember a little bit more. And that has to do with the safety of the treatment and the effort that's being put into a narrative recollection. But all of this avoidance, it adds up to diminished interest in participating in activities, feelings of detachment and estrangement. People who are, they're with their family, but they're not with their family. They always feel flat in someplace else. I had a Ethiopian survivor tell me about a lunch hour at the bank where he worked and how everybody was joining in on stories about barbecue and joking about children. And it was at those lighthearted moments that he most felt his symptoms of trauma, because he would ask me, am I ever going to feel like I can be fit in like that again, like I can be part of ordinary life? That's when he felt the detachment. Some people say it's, I want to play with my kids, but I'm not with them. My mind is always someplace else. I have a survivor I'm treating right now who was in a war, a refugee in a war in the woods, and when he takes his kids to the parks, he is preoccupied with not stepping on branches to make sounds that might trigger other people to know where he is. So it's hard to play with your kids when you're worried about stepping on a branch. You know, it's, so these are some examples, and it leads to a very restricted range of emotion because they're trying to keep a lid on emotion, very flat, trying not to feel. Sometimes this can be misunderstood when you're interviewing trauma survivors because, you know, we're America and we like an Oprah moment. We want people to cry about their bad experiences, and when they're flat, we wonder, are they really suffering? I would say in an initial interview you want to get a sense of that restricted range without getting into a whole lot of conversations, because if you go too farther with it, it tends towards dissociation and flashbacks. There's a reason people are keeping a lid on. And so you want to get a sense of those symptoms and a sense of how big of a problem it is in their life, and then move on to the other symptoms. Increased arousal refers to this inability to calm down. Difficulty falling and staying asleep, irritability. People would say they struggle with anger and they're uncomfortable with how angry they are. They go from 0 to 10. Everything is a 10, every little irritant. There is no sense of a 5 or a 4 or a 3 on an anger scale. Everything is a 10. They're on high alert. They've always been on high alert, and they're highly reactive. They have difficulty concentrating, constantly looking around, startle reaction. If you were to shut the door, they would jump. Anything makes them jump. Anybody walks up behind them, that's a startle reaction. This is, again, in asking about this kind of thing, you want to minimize re-experiencing within the telling of stories. So they may tell us, yes, I do struggle with this. I get angry when I this, and this. You get a few examples, but you don't want them back in that full emotional re-experiencing when you don't have an opportunity to resolve it. There will be time for that. These are definitional, and then the proposed revisions in DSM V focus on the negative cognitions and separate that out from avoidance. So this gets at the cognitive distortions that are in place following trauma, the pervasive negative emotional states, distorted blame, negative expectations of the world, is now is an additional criteria. Much of that, because PTSD is comorbid with depression at a rate of about 80%, much of those symptoms, those avoidance symptoms, you may find an overlap in diagnosing depression. So difficulty concentrating, thinking, remembering can be an avoidance strategy, but it's also a symptom of depression. Certainly thoughts of suicide and death. We have an uncomfortable suicide rate among returning veterans right now. We have a high rate among Bhutanese refugees. This is something you need to ask about in the initial interview, and if they endorse it, you spend a lot of time discussing it. And you want to minimize, again, re-experiencing. You don't want to go into the deep moments of despair, but at that point you're assessing who they're living with and what the risks are and what stops them from doing it and what supports need to be in place. You're basically doing a suicide assessment with them at that point. Depression includes, depressed mood, disturbed sleep, fatigue. I think what I noticed the most among trauma survivors who have PTSD and depression is just how slowed down they can be in conversation. And you need to be willing to go with that pace, and I'm going to talk with that in a minute. So we have about 5 minutes. So just some general principles then about establishing safety and trust. Obviously it helps with survivors of interpersonal trauma and survivors who have never had confidentiality and privacy respected to go into great detail and reassuring and discussing confidentiality. That goes a long way towards avoiding re-experiencing. Already the relationship feels different because there's an active, open discussion of safety and trust in the relationship. You always want to inquire among clients about how, in general, with all clients, how they feel about being there, but with trauma survivors in particular, to know how difficult it was to come and to validate and reassure. You want to address and normalize the reactions they're having that are so alien that have made them think perhaps that they've been crazy all this time. So especially in cross-cultural communities, there's a fear, and probably among some soldiers also, if I tell people about my crazy dreams or how much I'm suffering, they're going to institutionalize me and tell me I'm crazy. Like, they know their thoughts and their symptoms are not normal responses. I would address any cultural concerns related to age, gender. Can a man sit with a younger female? Can a young male sit with an older female? These kinds of issues, I would address them in forming an alliance. Provide a lot of validation for the feelings and fears that we've just discussed. Normalize reactions as part of psychoeducation. I'm going to talk about that in a minute. And really convey respect for their efforts towards healing. It helps to acknowledge that this is a very difficult journey, but it's a very positive journey, because when you do psychoeducation for trauma symptoms, which should be a part of every initial interview once you've gone through it, and even as you're going through it, to normalize the symptoms and tell people that post-traumatic stress disorder symptoms from trauma this is not an enduring, disabling condition. This is a treatable condition. It's very positive that they had the courage to come. That's what trauma treatment is all about, is separating those symptoms, resolving them, putting them in the past so that people can resume a normal life in a way. And so psychoeducation that normalizes these symptoms can be a very positive, hopeful part of the interview. And in my experience with survivors, it's very relieving when they hear that. They feel that others have these symptoms, and maybe they can get through it as well. So then, let's see. You do all that in the context of your broader assessment. Using assessment tools is common. You can see the trauma websites, the PDS. That's Edna Foa's tool. The Hopkins Symptom Checklist is the anxiety and depression scales from the Symptom Checklist 90. With children, people often use the UCLA PTSD. There's the civilian measures for veterans and their families, PCL, and then for depression, obviously we have the Beck Depression Inventory and the PHQ-9. These are all common measures used in assessment with trauma survivors. A caveat I would say is make sure when you're using these as a way to go through an interview that the survivor understands the response formats and the scales. I sometimes say, okay, here's the calendar from not at all to very much, from 1 time a week to 5 times a week. Here's the cups, the cup that's kind of empty and the cup that's kind of full. And when I ask you about these symptoms, I want you to point to the cup or the calendar that tells me how much you've been suffering with this in the past month, or whatever the scale asks in the past 2 weeks. Again, you want to acknowledge responses to items, but contain reactions and contain exploration to minimize re-experiencing when you're unable to fully process reactions. So when you use the PDS or you use some measure, and you've got 17 items, and on the first item, have you had problems with nightmares? They'll say, yes, the other night I dreamed of this and blah, and this happened, and I can't wake up, and I can't get back to sleep, and they're going on, and you're on item 1, You have to get through 17 items. So it's the art of being empathic and containing, normalizing, and moving on. And you don't want them to re-experience too much in the interview, because what does happen with some, novice therapists have just let the person come in and they are uncontained and unregulated. They've been waiting to talk about this forever. They start to talk about it, spill the whole story in the first hour, and then they never come back because they have so much aversion to what they just talked about with you. And we already know with a lot of these exposure therapies that the dropout rate is pretty high, as much as 50% for some of them. So it's very much about, at the end you want to know how did this go for you, and encourage them to come back and to call if they have difficulty coming back, those kinds of things. So here, I'm right on that. Some survivors will rattle off trauma experiences at an overwhelming pace, so that they want you to feel their sense of too muchness, which you very much can feel. So I would say it's important then to slow them down and reassure them that they will have time to tell their story, and that you want to hear it all, but we both want to hear it in digestible units and digestible pieces, so that we can get back to a normal sense of stimulation in life. Your job is to organize and contain and help people digest when you are the therapist. With other survivors, you need to be comfortable with a much slower pace that addresses trust and cultural issues, especially if they're depressed. They may be wanting to get on an SSRI at the beginning of treatment. They may not remember what you just told them 2 minutes ago, so you need to be very patient with repeated, elaborate explanations, simple language, we'll have plenty of time type of language. Sessions go very slowly. You want to really address re-experiencing and dissociation in the session when it comes up. Sometimes you cannot control that being triggered. And what I would recommend is that you interrupt. We do not want dissociation to be happening in any clinical interview because it's not helpful. And so I would just go back to trying to ground the client. You refocus their attention to the current situation in the here and now. Sometimes I say, I want you to come back to me now in this room on this September day in this year. Let's put your feet on the ground. Let's do some breathing together. There's simple relaxation breath exercises that I keep on hand to make sure that people are in their body. You can use any of those. You want to, when you're assessing if people are grounded and ready to go, look for color in the face. You don't want them to be white. You want to see the color in the cheeks. To look that they're calmed down, I ask them if their heart is beating fast or if it's calmed down. It also helps to then just reorient it to the day. After this session, what are you going to do today? Who's driving you home? Sometimes I suggest that clients take a walk for a half hour around the building or the neighborhood before they get in their cars if something like this has happened. But have a sense of their activity for the day. Are they going to be with their families? What are they going to do? It helps if they can access current sensations like hunger. I feel hungry, I'm going to go have lunch, or it's warm, I feel warm, something like that. And it helps to provide some cognitive explanation. Now, when you went off like that and you were out of touch a little bit? Were you aware that there was a long period of time and we weren't talking, and I asked you to come back to me and your vision went off to that story? We call that dissociation, you know, and we want you in here to be in the present. We want to be talking about your stories in the present. So when that happens, I'm going to help you get back and feel safe, and we're going to learn how to notice when that happens when you're not in session. And so it's about creating a safe space for talking about symptoms where the person knows they're talking about the past but that they're safe in the present. And that starts right from the get-go in the initial interview. Certainly it's part of treatment, but I think I'm at time. Or over time?
No, you're perfect.
Okay.
We need to get questions.
Okay.
So thank you, Dr. Shannon.
Sure.
For those of you who are in our online audience, if you haven't already sent in a question, you certainly could do that now. There's a little envelope at the top of the screen where you have the image of Dr. Shannon that you can click on that, and if you have a question, please write it into that. We have Charlie here ready and waiting to be able to say those. Oh, I'm sorry, it's not the envelope, it's the pinch bubble. Speech bubble. Not the pinch bubble, the speech bubble. Okay, and anybody right now who is in our audience in the room, do you have a question while we're waiting for others to respond online?
So you mentioned that during the interview process, questions can trigger people. When you see the rage, you're pretty aware of that. If they just go deep inside and you don't know that you've done that, how are you aware that these simple questions may have triggered something? Do you just every 2 minutes stop and say, how you doing? You feeling okay? Is there anything I've said so far? Blah, blah, blah. Or how do you notice that if it's not a rageful or real visible response?
Yeah, I mean, to a certain extent, you're asking them to talk about their trauma, so the whole thing is triggering. I think what you're suggesting is not such a bad. If someone is really slowed down and interior, and you know you're coming to the end of the session and they've answered your questions, but you don't know what's going on, then I think it makes sense, for the sake of safety, if that's what you're concerned about, to just say, tell me a little about what this was like for you. What are you thinking now? Because then you have then you're done and you have a little time to explore how it was for them. One of the things that happens in these trauma-focused clinics is people get so efficient about their assessments. They have no idea what they have just dragged someone through. And it is possible for the survivor to say, I don't want to go back to that person again. After the first, like, that was a really excellent assessment, but don't make me go in there again, you know. So you do want to know, you know, how tough was it? And so what I do with the assessment measures, which I forgot to say, is I go through them. When they're completed, I look at what they've endorsed at the extreme levels. And then I always go back to the extreme levels. So you endorsed, especially if it's suicide, then that's the first item I go to. Tell me about that. Let's understand that. But they might endorse things like guilt or sense of worthlessness, blaming myself, nightmares at extreme levels. Anything that is endorsed on an extreme level, I want to reassess to know how bad of a problem it is, and is there anything I need to do right now. It informs referrals for psychiatry, other things. So yeah, I think if someone was real quiet and I didn't know what was going on, to answer your question, I would inquire a little more.
Dr. Shannon, I was thinking about trauma in the context of substance use treatment programming, and how oftentimes a person will go through a very efficient assessment, be asked about their trauma, and then they'll be put right into a group, even though there is a history of trauma. And many of the things that you were describing, concern about being in a crowded environment, fear of lack of trust of others, and all of a sudden they're thrust into this group environment where they're expected to participate. They don't, so they get in trouble, and then they're either kicked out of the group, kicked out of the program, or they have a lapse. I don't expect you to solve this, but it seems like there's work to do within substance abuse programming to have a greater awareness of how trauma influences a person's ability to participate.
Yeah, and I'm really impressed with some of the blended forms that have of treatment that are out there, treatment programs for substance use where there is trauma, or there's other, like DBT is an example of an integrated program that focuses on basic skills prior to trauma resolution. I think the more you can pay attention to the variation in the survivor community, the more successful they're going to be with these added treatment components. And certainly any group treatment, you set initial norms around confidentiality and trust and expectations. And if a trauma survivor can't even do that in the first session of the substance use group, then it's probably not appropriate, right? I mean, I'll defer to you because that's not my expertise. But I think you are picking up on some of the challenges for trauma survivors being placed into any processing group like that. Yeah.
Is there any therapeutic value in actually reliving the experience?
Yes, that we would call trauma treatment. And I think to successfully engage in treatment, you want to minimize how much that re-experiencing is going on in your initial assessments, because when you start an exposure treatment, it is about re-experiencing. So if I looked at this particular fear network, we would ask this child to tell this story, but tell it in a way that integrates her sensory experiences, what she was thinking, what she was feeling, what she sensed in her body. So when you do an exposure treatment with someone like this, you say, okay, you entered the garden and you saw, and what were you thinking? You weren't imagining about the bombs, but what were you feeling just at that moment? Don't go farther in the story. Tell me how afraid you were. Were you afraid, and how did you feel that fear in your body? Okay, now move farther in the garden. You see the bomb falling. Okay, what were you thinking then? What was your body? Well, my legs were running. I guess I was hot and sweaty. I could hear a scream. You slow them down to integrate the reliving in a therapeutic declarative memory. And that's different than re-experiencing symptoms and suffering in an unintegrated, untherapeutic way. Does that make sense? Like when you relive trauma in the context of therapy, it's with therapeutic outcomes in mind, that this becomes a story that is finally processed and put in declarative memory where it should be, and not reliving in a chaotic, unintegrated way that is just a reliving, re-experiencing of symptoms. Because when you do that through dissociation, it's damaging to the brain. When you're just re-experiencing symptoms, and it's not in the context of a therapeutic narrative, it's not helpful.
There's a question here
Yeah.
that came through the internet. How do you respectfully keep someone contained when using an interpreter and they start spilling everything out? Do you use hand gestures or interject once?
Yeah.
Ask the person to slow it down?
I just interrupt the interpreter. I just say, okay, I can see there's a lot going on here, and I need to interrupt and ask what's going on. And then the interpreter will tell me. Yeah. It's best if interpreters are trained, meaning they're trained ahead of time on what their role is and their responsibility between the client and the therapist, so that they know. Some of them have their own sense of pacing, and they will tell the client to pause, to hold off for a minute, so they have a chance to tell. Because if too much talking goes on, they can't remember what they're interpreting, you know?
How do you handle a situation where you have a male therapist and the trauma is really related to rape?
Yeah. Well, I think those kind of gender issues need to be discussed, or any cultural age, gender-related issue needs to be discussed when you're forming a treatment alliance. When you're talking about confidentiality, you're talking about safety, the kind of relationship you're trying to create, you're explaining the goals of treatment, and then you want to ask, is there anything that would make you feel uncomfortable here? Research shows that the treatment alliances that are most successful are the ones where people can negotiate differences, where they can voice questions, where they can discuss opinions and differences and negotiate them successfully. So you want a successful negotiation. Sometimes you can't get that, especially when you're working with an interpreter. I had a young female client, Mandingo client, and a male interpreter, because it was impossible to find that language. It had to be a male interpreter, and then me, and she was a rape survivor. And I said to the interpreter, how difficult and unusual is this for you to be interpreting for me with this young girl in this situation? He said, it's really not normal at all. This would not happen in my community. It's not appropriate. And then I said, okay, let's talk to her about, let's acknowledge that, and let's talk about our situation. We cannot find another interpreter. And can the three of us find a way to work together respectfully that's going to work for her? Otherwise, there's no point in doing it. You have to form a treatment alliance. You have to negotiate these differences. I think there's a lot that men can say to convey their respect, to validate their sense of violation, and they also offer a role model for women who've never experienced men as empathic, as having appropriate boundaries, as being safe people to talk to. So there's potential in difference as much as there is difficulty, and it's all about how you communicate and navigate it. I wouldn't say across the board that a man could not work with a young woman rape survivor, but I would respect that preference if I could. If she says, it's not that he's not a nice man, I just don't want to talk to a man, and if you have the option to make her comfortable, then I would probably try, but it wouldn't be my first thing. I would want that conversation to go on, if that makes any sense. It's not unnavigable. Yeah. Is that it?